Welcome to another episode of SGH Hospital of the Future podcast. I have two lovely ladies with me today, and I'm going to let them introduce themselves. But we're going to talk about wide-ranging topics, everything from infectious diseases to epidemiology to why people want to be in Asia and what we should do in Asia for hospitals of the future. So first, my co-host, Professor Jenny Loh from the Department of Infectious Diseases. Jenny.
Thank you, Suyen. I'm very happy to be invited to be part of this podcast session. I'm Jenny from Department of Infectious Diseases, Singapore General Hospital. I also have a faculty appointment with the Emerging Infectious Disease Program over at Duke NUS Medical School.
My name's Azra Ghani. I'm a professor in infectious disease epidemiology at Imperial College London, and I'm also here in Singapore academic director of Imperial Global Singapore, which is Imperial's hub for the region.
Do you want to start by quizzing her?
Oh, I would love to. There's a question that I've always been dying to ask a modeler. It's like, how do you explain mathematical modeling to I would consider myself, even although I'm an ID physician, I think when it comes to modeling, I consider myself a layman in my understanding of what a model can do. And I think, there are a lot of jargons as well in mathematical modeling, like, what's a model, what is prediction, what is scenario. Can you distill all that and demystify it for us?
Well, I'll certainly give it a go.
Okay.
Obviously it's a complicated field. I think the first thing is I actually come from a mathematical background, and I think the first thing I learned a couple of years in, never put equations up in front of people because you lose most of your communication that way. So to get across what a model is, it's really a way of trying to think about put together the logic behind how we make decisions. So in infectious diseases, we might have a number of different interventions, and we're trying to consider and weigh up the relative use of each of these. And our model is just simply a way that we formalise how we put that information together to try and help the policymaker or anyone make decisions about what might be the most effective way to do that. So it is just essentially that a model is a set of rules. We generate those rules. We then test what they produce in terms of scenarios against what we're seeing, and we try and understand those patterns. And then if the model seems to be able to reproduce the current patterns, we can feel reasonably confident about generating forward scenarios.
And how do we know what we don't know? If you're talking about the field of infectious disease, which moves very fast, how do you just keep your finger on the pulse of what is important that goes into a model and what kind of gets deprioritized, and how that predicts things for you?
Well, so reality is really, really complex. So a model is not there to try and capture everything that we might want to put in. It's really trying to capture the salient points. And that's something that's, of course, evolved because it's a very well-developed field over time. We have a fairly good understanding of what is going to drive epidemics. So we know how transmissible infections are. That's a key driver. That magic number called R0 that I'm sure everybody has now heard about since the pandemic. It's just trying to tell us how fast infection is spreading in a population. And then the other key thing that we always are worried about is how severe is it? Because if it's an infection that's spreading and not many people are actually getting symptoms or getting very ill, then the sorts of interventions we might want to put in place will be much lighter than if something's moving very fast and has quite a lot of potential health impact.
So has there been a situation when the prediction didn't go as anticipated, and how did you then have to deal with, say, whether the public or the politicians then deal with the fact that the prediction didn't go as predicted?
Yes, no, that's a really important point because of course it's very hard to predict the future. If you look on your weather app, how many times is the weather predicted right? not very frequently here in particular. So it's not really always a case about making predictions. It's a case about exploring the knowledge we have at the current time and seeing what potential scenarios that might produce going forwards. And that's why we often try to distinguish between scenarios, which are things that might happen if we take action A over action B, versus saying we can absolutely predict how many cases are going to be a week from now or a month from now. That's also, though, difficult to communicate, and I think we've all experienced that, particularly during the high pressure and the visibility of the pandemic, where often our numbers, because they are numbers and not just words, get put in place and communicated quite widely as if they are predictions. And then inevitably, they are going to be out.
I'd like to ask both of you, maybe starting with Azra, but your journey in infectious disease, how did that happen? Starting with a background in mathematics and then transitioning to infectious disease epidemiology. Would you have predicted that for yourself when you were, doing? Yeah.
No, I did a really quite pure maths degree. So when I got to the end of my undergraduate, I mean, this was the days before the internet, so just I went to the careers service and said, what sort of applications are there for maths? And I think at those times there were far fewer, but one that came up with something called operational research. And so I looked that up, and it was applications to scheduling, to landing planes, to scheduling lifts, all sorts of things. And I started off deciding that seemed a good idea. So I went off to do a master's degree. Then I discovered my planes were crashing and my lifts weren't coming, and this really wasn't working very well. But what I did pick up and was exposed to during that one-year course was this infectious disease modelling. And that really piqued my interest, and I think it was maybe that link between the biology and the maths that was actually particularly interesting, because biological systems are quite complex and quite non-linear, so there was quite a lot of interesting outputs from a mathematician's perspective there. So that's how I moved into it. I moved into epidemiology and have been there ever since.
Yeah, fascinating. Yeah.
And for you?
I don't do medical math. I don't do modeling work.
But why infectious disease? Why the study of viruses and?
I think it's because it really is the unpredictable nature that's really exciting, and we all. So Suyan and I went through the conventional path, right? We went through medical school, then we decided on the discipline that we want to specialize in. Yeah, but when I got into infectious diseases, I think I like infectious diseases because of the diversity, and I eventually pivoted to viral research purely because I thought that there is so much of uncertainty, and I think most importantly, not many people are very interested in it. Yeah, so then that kind of got me hooked on.
What do you think we've learned from the pandemic, which is now more than half a decade ago, although some days it seems like just yesterday? What do you think we've learned, and what do you think we still haven't learned? And it's an important message for people who build hospital systems, for CEOs, for government bodies, for ministries of health.
Yes, it seems like yesterday in many ways, but we've moved on quite a lot. And I think we've moved on as a society, and maybe too much. I mean, it's good to be able to sort of almost forget that past. But I think it was such a good reminder for everyone of the risks that infectious diseases pose, because it's not the first outbreak, and it's not even the first infection that we might consider a pandemic that's certainly affecting more than one country. There were many examples before that. I certainly worked on the first SARS outbreak, which back in 2003 seems a long time ago, but was really a big issue here. We have flu, we have Ebola still going on now. So these infections are out there and continually challenging us, and I think everybody at least learned and was much more aware of the threats these pose. But at the same time, I think we've almost reacted in a way that we don't want to believe it will happen again. And that risks not being prepared for the future.
Yeah, I totally agree with that. It's like the moment the pandemic was over and, we went back to business as usual. Yeah, there was almost like a little disappointment on my end that we want to so readily forget what we have gone through in the 2 years, 2020 to 2022, and it's sad because that also means that a lot of the policies, the strategies that we really need to think about for pandemic response, then again get deprioritized. We saw that with SARS in 2003. I was a first-year trainee when that happened. Yeah, and I mean, I'm sure Sweden was also affected because essentially, because the Singapore was quite badly affected by SARS, and Singapore General Hospital was also affected because of nosocomial transmission, and we were all essentially we had to temporarily forget that we were each in our subspecialty training, and we were doing general medicine and doing a lot of damage control essentially, yeah, and again, I kind of feel that, so with SARS one, we felt that, once the epidemic was over, everybody forgot, and we went back to business as usual. With SARS, with COVID-19, I almost feel that again, right, is history repeating itself again?
Yeah, and I was excited during the pandemic. One thing I was excited about was that we'd learned so much about respiratory diseases and how to reduce the burden. And what we saw was a really big drop in influenza, for example. Yeah. And it just made us think, well, if we just kept some of these less restrictive things, like wearing face masks when people have symptoms, much more frequent here than it is in Europe, that would really have a big impact, not just on flu morbidity or mortality or sort of deaths, but also on hospital capacity. So we really struggle every year in the UK with very full hospitals over winter, a whole bunch of viruses. And I think the pandemic taught us that we could prevent those.
Yeah, that's right. And for whatever reason, right, a lot of these investment have been pulled back, and I guess resources again rechanneled to other areas. Yeah.
What would help us be a bit more resilient? If you could influence policymakers to say, look, there has to be a constant state of pandemic preparedness. Is it an IT system? Is it people's mindset about social responsibility? Not coming into work, wearing a face mask, kind of thing. Or what would you wish so that this doesn't repeat itself?
Yes, I mean, hopefully we will influence, but I think it is exactly that. It's multifaceted. We can't just rely on one thing. I think historically we've felt that we would rely on something essentially therapeutic. So as long as we have our therapeutics and our vaccines, this is sufficient. And it's certainly really important, and we have the 100-day mission globally that's really trying to make sure that these both diagnostics, therapeutics and vaccines are available very much more rapidly and to all populations. That's important, but it isn't sufficient. And in fact, what we really need to do is to have the systems in place to be able to prevent an epidemic or an outbreak escalating. And then our investments in these other tools maybe aren't so necessary if we can really contain things at source. And that isn't just a health problem. That requires a whole of society approach, because it requires people to recognise when this is happening. It requires systems in place across government to be able to flag and act appropriately. And it really does involve bringing the community along in place as well.
I absolutely agree with that.
Yeah, and while dengue isn't really high on the list of things that you watch out for in the United Kingdom, I assume.
We do. Well, we don't have dengue yet, but there was a cluster of dengue cases in Paris a couple of years ago, so it's certainly on the list, and we've now started surveillance in mosquito populations.
Whereas she's, our world expert on dengue.
No, I won't call myself a world expert, no.
Is there anything more that you think we can do? Is it in therapeutics, or do you think it's just in community awareness? in the work that you do? I know a lot of your work is bench work in that sense,
Yeah.
right?
Not really. Actually, a lot of my work is more translational, clinical trials, vaccines, antivirals. But I think when it comes to dengue is really a very complicated disease, right? Yeah, we now realize it's not one disease. We're dealing with like probably 4 distinct diseases with 4 different serotypes behaving fairly differently. And I don't think there's one single strategy that will control the disease. I'm not using the word eliminate. I think that the bar is really high. If you want to talk about the dengue elimination, we can although come back to malaria elimination. Yeah, so I think when it comes to dengue, it's a multi-pronged approach, right? You need vaccines, you need vector control, you need antivirals, you need community engagement, environment control, etc. And of course, there is the part that really is very challenging right now is climate change and how that's also influencing vector behavior, etc. Yeah, so it's a complicated and challenging problem, and and maybe with that we can ask Azra about her work in malaria, right? Because she has done an amazing work with advising WHO when it comes to malaria control in Africa.
Again, another infection transmitted by mosquitoes, but very, very different in many ways. It's a parasite, so it's very complex, and it's been challenging because of the diversity of environments in which malaria is sustained. So here in Asia, obviously none in Singapore. Singapore eliminated malaria in 1982, I believe. But it still is an issue in parts of the region, in parts of Indonesia, for example, in parts of East Malaysia as well. And the challenges there are that you need to continue to keep, even when you've driven down malaria to low levels, you really need to keep the surveillance in place. And I think the biggest challenge with malaria elimination is not necessarily driving down to low levels, but keeping the political awareness that you need to keep these systems in place to prevent resurgence and reintroduction. And that's a very difficult case to make, because if you've got a limited budget and you've got multiple health problems, to suggest that you need to allocate some of that money to something that nobody can see and nobody is aware of is really challenging. And that's always been the issue with elimination of any disease. We're seeing it with measles. Vaccine uptake is dropping off. We're seeing resurgent epidemics.
And you both have a role to play in global health. I mean, I think it's especially pertinent when you're talking about infectious disease. What has that translated to for you in terms of where do you feel you can influence the most? And I mean, coming from United Kingdom and Singapore, which are fairly affluent in that sense countries, right? How do you translate that into scenarios which are more resource constrained?
Actually, the UK is quite resource constrained in its own way when we talk about our health system. But I think it's thinking of ourselves as a global community. There is a really strong global health community, I'm sure Jenny feels the same, that we interact with and we learn from, and that learning is bi-directional. So certainly during the pandemic we reached out to all our global contacts that we'd been working with on a whole range of different infectious diseases, and we learnt from each other, and we found our way, slightly fumbled our way through the early days by learning together. So I think that community is really strong, and that then enables us to jointly tackle problems. So we're not going into places and saying, we're coming from country X and we know how to do something in country Y, but we're working together to learn from each other.
And for you, your work in the region, you've got collaborators in...
I think we are very lucky in Singapore, right? It's a first world country, we're fairly affluent. When it comes to access to drugs, generally we don't have big issues with affordability and accessibility. But I think, we need to think a little bit broader in terms of the needs in the region. Certainly we are I mean, in this part of the world, there are many countries that don't have that the population with who don't have the means to to even afford a lot of medications. I mean, even simple medications like antibiotics, right? Yeah, and there are also counterfeit drugs, etc. that are very common in some countries in the region. So I'm actually quite passionate about trying to find ways to reduce drug development cost. Yeah, how do we, how can we change the way drugs are discovered, tested, all the way from preclinical to clinical, the entire chain of development? How can we look at how costs can be reduced every step of the way, all the way to the market? Yeah, because it's only by doing so then are we able to bring down the cost of these drugs when these drugs enter the market. Yeah, and hopefully by doing so then the drugs can then be made more available, right, to the people who really need them. So that's something I'm personally quite passionate about.
Yeah, it's a really important issue, because the other problem certainly we've had with malaria is almost market failure, because there isn't a market to be able to afford to buy quite expensive products. So something a number of people have worked on is a sort of a product development partnership. So that brings together philanthropic funding, government funding, international agencies to de-risk some of that development process so that those things can go through. And that's indeed how we got the first malaria vaccines, is through that approach. But it is a really important point. And then the other issue is at the point of the market, who's going to be able to afford and access these drugs, and that's critical, and that's thought about, and it also fits within the healthcare that's locally available.
You've just moved to Singapore recently, this year?
I have.
Yes. Has anything surprised you? It could be a positive or negative way.
No, I mean, I'm really enjoying being here. It's a wonderful community, it's very welcoming, very easy to get set up, as we were talking about earlier. Systems all work, and yeah, I'm a systems person, so systems that work is really great to live in. But it's also really a fantastic scientific community. I'm here for the science. I am a scientist, and I've met many people that I've had fantastic conversations with, so I'm very excited.
Do you have one negative thing to say about Singapore?
Not really, no, not yet. Maybe I'll come back in a year and think about it.
Yeah, and I mean, how is this part of Imperial's plans, and what are your hopes?
Yes, I mean, so at Imperial we've been working obviously internationally for many years, and we have partnerships around the world. But most recently we developed a new strategy, really trying to bring together our scientists across different domains to address some of humanity's biggest challenges. And I think part of the realization in doing that is that you can't do this alone. You need to work in partnership, and you need to work in global partnership. So we've actually set up 4 global hubs. The first here in Singapore, others in Bengaluru, in India, in Accra in Ghana, and in the Bay Area in San Francisco. And all of these hubs, we're all working slightly differently. Our hub here in Singapore is very research focused because of the really strong research environment and the potential for partnerships. It's also a regional hub, so whilst we have great collaborations in Singapore, we're also linking up with other regional partners. And so it's really there to drive our research in collaboration, to think about new ways that we can have impact, to partner with government, wider agencies, and really take the science out of the laboratory and make sure that it has impact on the ground.
Are there specific domains that you hope to focus on?
So we're covering all of science, which has been an incredible challenge for me, but also fascinating. So our current projects The largest one is looking at cybersecurity of medical devices, and it's actually a project that is in collaboration here with Sing Health. So we're looking at some of the instruments in the hospital, looking at their vulnerabilities and working together to work out ways to secure those instruments. I think that's been a fascinating area, something I knew very little about. But we're also working on decarbonisation. We've got some new projects starting with a very strong AI focus, like much of Singapore's science. So we're not restricted to any area.
Okay. So I assume now in your new role, you are moving from doing the science to leading the science, and how do you feel about this transition?
I think it's been a gradual transition, if I'm fair, because there's a point at which you don't do the science as well as some of the younger generation. Yes. And I've always found it's been amazing to learn from the people around me, and a lot of the people that I've mentored and have come through the group have been fascinating, and I think they can do things so much better than I could have thought about it. So I really enjoy bringing people together to solve problems rather than thinking of it in isolation. So to me, this is just a natural progression of doing that and taking it to scale, essentially, by being able to bring together multiple different disciplines, bringing engineering, bringing business people together along with medics, to think about how we each take our different skill set and different perspectives to solve these problems.
And that would be the philosophy behind convergence.
It's exactly that, right? It's essentially coming from particles. If you think about particles in a gas, it's a bit science and a bit nerdy, but knocking together. How do you move from what we have at the moment, which is a lot of interdisciplinary science, which is essentially people do come together and they partner, but they keep their science the same. They just bring their science process to work together. How do you actually get people to change how they do their science in their disciplines? And that takes quite an open mindset to begin with, and that can be challenging. You've been trained very specifically for many, many years. And then to think about the problem you're trying to solve as the first point rather than the method, because that allows that flexibility to happen. So it's certainly something we're trialling. It's challenging, I would say, but I think it's an interesting pathway to take.
Yeah, because probably 10 years ago we wouldn't have been talking about implementation science or convergence. Yes. And it's very relevant now. Yeah, and I think the more interaction we have with your team in Imperial, it's also something that we should grow.
I sometimes, just off the cuff, as we are talking about convergence, right? Yeah. I somehow feel that actually we lack engineers in the medical discipline, and we are beginning to realize how important it is to have engineers among us.
Yes, yeah, absolutely. I mean, it is a field that we have realized, right?
And you have here, because our bioengineers are working with your bioengineers.
Yeah, absolutely, yeah. And which was leading to my next question is we now have job descriptions and that we wouldn't have had before. And we always talk about our clinicians needing to speak other languages, whether that language is IT, whether that language is data science, whether it's engineering, or coming from mathematics, for example, into infectious disease or into epidemiology. Are there any other areas that you've kind of realized over the past few years that we can't be siloed into our little niche area of expertise anymore? What else? A bit of crystal ball gazing, but what else is going to be important for us?
Yes, I mean, I think it maybe comes back to the very rapid growth of AI, which is often talked about, but not normally in any depth, which is quite interesting. But I think psychology is coming in there. Because we're changing how we interact, and we have been gradually over time in the whole process of social interactions, in the very much online environments that are going on. And there's something deeply intrinsic about human interaction that is different from some of those elements. But I'm sure we've all experienced it. We've taken our favourite AI tool and we start having conversations. Yes. And it's just a really strange thing when you step back and think about it. But you naturally start doing it. And so I think that element, hasn't been thought of so much in science. It's almost seen as a separate discipline. It's something I came across at Imperial because we actually have psychologists in our engineering faculty under design engineering, which is really thinking about when you're designing new products for markets, what's going to appeal to people. And you really need to understand how people are going to interact with them. So you need to think more about the people side. I think that's important for implementation science. We've tended to think of sociologists as being the implementation science people, and maybe not also added in that psychology.
Yeah, I mean it's true, right? We have been brought up to think like Azra says now. We are all very siloed, and we all think in a particular way. And I think when it comes to the softer side of medicine and science, we tend to poo-poo it.
Yeah.
Right? We tend to think that it's so fluffy and so.
I think medicine's better than most scientists, to be fair. You need some bedside manner, right?
Yeah, but no, you're right, because I mean, at the end of the day, the implementation part also, if you don't understand the human psychology and the way the humans are going to react to that, you were never going to get that. When you talk about weight loss, for example, right?
Exactly.
Or you talk about, dengue prevention or vaccination, which was a huge, basically a huge global study in people's reaction, from policymakers' reaction to your citizens. Yeah, have we not understood the psychology behind people's reaction to the medical information, that scientific information you're presenting them with? So we need to build yet another facet into our medical education. I will leave that in Jenny's good hands to shape that for Sing Health. Yeah. Do you have other things on your wish list? Because now you're at a position where you straddle UK, Singapore scientific interactions, directing things like global health and convergent science. What else? I'm sure you have a lot of things on your list, to-do list.
There's a big to-do list.
Yes,
certain,
yeah.
Yes. No, I mean, I think it is coming back to that working together piece, and how we really get people out of their silos.
Yeah.
I think that's challenging in science, in particular, especially when you get into some disciplines. It's always difficult for people to think about what's the advantage to me. It's making that case for people to get out of their silos. So it goes beyond, it's almost like another piece of psychology. What's going to persuade someone that it's a benefit for them? And it's essentially some sort of nudge behaviour, much like we tried with many things in the pandemic, of trying to get people to gently change, at the same time as technology is almost forcing a very rapid change. So I'm a glass half full person. I'm really positive about AI. I know there's a lot of things out there about the risks and the concerns about it, but I think we're an adaptable species. We will adapt to this, and we'll learn how to deal with it.
I mean, it's not going to go away, right? We jolly well adapt.
Yes,
to it.
We have to. Yes, yes.
So on that note, we have, both of us have gone through a very, very conventional path in our career. You, on the other hand, have done a rather unconventional way, right, of first being a mathematician and then eventually landing in infectious disease epidemiology. I'm just wondering, I have teenager children. If I ask one of them to come and speak to you and get some advice from you, what will you say to?
I think I have had quite a conventional linear career in a way, in a strange way. It's because I've never moved outside of academia. And actually, what I've seen from the people that I've since mentored and gone through, increasingly people are moving. And I think that's a really positive thing. So many of our students, both coming out of a PhD or maybe having done a few years of postdoctoral research, they move into all sorts of areas. It might be government, it's often charities, and there's quite a lot of movement generally around. And I think that's a thing we should encourage more of. So coming out of our silos, which probably includes me as well at some point, a little bit too late maybe, but just moving outside of it. Yes. Well, it is and it isn't, right? Because there's a sort of thing about institutions as well. You get very comfortable, don't you? You know how it works, and you're comfortable staying there. So yes, I still think there's a big world out there. I think the one thing to say to young people is it will work out, because there's always the ups and downs, and you've got to have the downs to feel the positives. And it is a tough environment at the moment.
I think we should get more of our Singaporean students to come and interact with Azra.
Yeah, I think so. No, absolutely. I mean, firstly, the mindset of pivoting, right, which means you keep yourself open to possibilities. And then we also always say you don't really learn till you've failed, which runs counter to, I suppose, a place like Singapore, where we always want, the children to be set up for success, not realizing that we might be doing them a disfavor if they don't experience.
That's one thing that definitely feels stronger here.
Yeah, if we don't, if we don't allow them to fail, what do you feel as a parent or as a mentor or as a program director, and learning from the failure. So the important thing is not the failure. It's learning from the failure and and improving on yourself or the process after that. But it's a journey for all of us.
Yes. And actually, even the other thing I found very helpful is to admit to our failures. Yeah. So, for example, one of the things we started doing, when we started a grant writing workshop. In the past, you might have found the professor come in and say, well, I won this, and this, and that's all you see, all the things that worked. So we start off with the much, much longer list of all the things that failed and why they might have failed. And sometimes it's just bad luck. Yeah. And just putting that across, that it isn't a reflection on you, it isn't a reflection on your ability, this is just part of the process. So I think collating those failures and sharing and being open about them really will help the next generation as well.
What do we learn from our failures during the pandemic, for example, that you think, if you speak to policymakers and the hospital C-suite to make, SGH, as we do future planning, what do you think? Is anything missing from our plans at the moment? Would you have a wish list if we asked you for, ID research, hospital structure? You get to answer first, and then we'll leave Azra with the tough summary.
Yeah, I mean, to be very, very frank,
Yes.
I really didn't have to deal with all those tough decisions that you spoke about, and whether certain policies, certain strategies that we put in place didn't work during COVID-19. I was very glad that I wasn't put in that tough position to make those tough decisions, because I was very much more involved in the research in my research capacity. Yeah, but I mean, I think in general we had done very well how we responded and managed the pandemic. But as usual, right? Definitely there would be areas that could have been better managed. The one thing that came to my mind immediately when you mentioned that, obviously, was how we dealt with our migrant workers. Yeah, so that was that yes. Really didn't in the early days. There were a lot of I'm sure you knew, right, that how they were treated and how they were confined within the dormitories, and etc. I think a lot of that could have been dealt with better. I'm also glad that actually, because of the pandemic, a lot of things have changed, and now actually the conditions have improved tremendously because of what we found out and knew from our pandemic experience. Yeah, but in short, I didn't have to make those tough decisions. Thank goodness.
Maybe you're going to have to next time.
And for you,
yes. I mean, so many things did go wrong. And I think you have to admit to those. I mean, I feel quite comfortable in the choices that we made at the time. And again, we weren't making the decisions, we were providing the scientific advice. Certainly, I think the first 3 to 4 months of 2020 were probably the most stressful, partly because a lot of the world around us had not woken up to the threat. And so that made it very difficult to communicate. So there were things that were wrong, but how would we change things in the future? I think one of the most challenging pieces was not maybe the external piece about what we communicated or how we went about that, but it was actually trying to keep the team together under an immense amount of pressure. And I think that I probably learnt the most from, about how people react under pressure, how to try and work together, what works, what doesn't work. So I think that's an area that I felt we always need to focus more on, but unfortunately that never happens, because you never really get the time to spend enough consideration of how structures might work better. But I think it would be really helpful in thinking about future preparedness.
Any last words for our audience about?
Any last words? Well, I guess just to be aware that infections are still with us and will always be. I don't think that should be something that anybody should be worried about. But just keep an awareness of what's going on. We see an awful lot happening in the newspaper. Sometimes that's a little bit more alarmist than we necessarily feel. But I think just having that awareness, trying to keep that social responsibility that, if you've got symptoms, try not to go out and pass these on, because there may be somebody who you can't visibly see is more susceptible.
Yeah. Well said.
Well, thank you very much, Jenny. Thank you, Azra.
Great.
Thank you,
And
Suyan.
we've covered everything from mathematics to masks to mosquitoes to medicine. And thank you very much for joining us for yet another episode of Hospital of the Future.